Hello, and welcome back to our clinical case series. Today we're going to focus in on the mandibular anterior sexton. This is a fun case. We're going to see how I built the ridge, augmented it, allowed it to heal, and then designed a surgical guide and placed the implant. So you're going to get to see this case from start to finish. This case took over a year to complete. So sit back, relax, and let's dive in terms of how to manage horizontal ridge defects in the mandibular anterior sextant. There are three learning objectives I want you to understand and take away from today's presentation. Number one, I want you to be able to diagnose and treatment plan a mandibular incisor ridge defect, including the assessment of hard and soft tissue, and determine the indications needed for ridge augmentation and delayed implant placement. I want to utilize 3D treatment planning using DTX Studio to virtually plan the ridge augmentation and the ideal implant positioning and translate this into a precise prosthetically driven treatment plan. Finally, I want you to be able to design and fabricate an in-office surgical guide using the SprintRay Pro 2, then execute the guided delayed implant placement and evaluate the clinical and radiographic outcomes of the ridge augmentation. So sit back, relax, and let's spend about 10 to 15 minutes with me going over this case. So here's the initial presentation of this mandibular incisor. You can see from this presentation, we are missing tooth number 25. But what I want you to really notice, and you can't take appreciation of this yet radiographically, but notice the root prominences that I see in this mandibular anterior sexton. Not so much here on number 26, but on 27. So you can see here, I know before I even get into this case that the bone is thin in this area. It's more of a what I'd call a washboard type effect. Now you haven't even seen the radiographic defect here at site number 25. However, what you do know about this site, or what you understand, is that there is bone at the level 2 millimeters apical to the CEJs at the adjacent two teeth. Very important here, right? I know that the papilla heights are high because the bone is high. If we were dealing with a case where the papillas were more apical, I would know that there is a vertical component to this ridge defect. Again, you look here clinically, you're thinking, what ridge defect? Maybe, are you referring to this, Dr. Peterson, right here? That? No, 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 no. Let's look at this radiographically here on the next slide. The one thing I want you to notice, though, is we have an abundant amount of thick keratinized tissue. I think that's our saving grace in this case. So this tooth was removed by a previous provider due to an apical infection. So you can see in the cross-sectional images, look at the loss of bone. There's a big horizontal and vertical component missing from this ridge right now. So what do we need to do? We need to go in and create a surgical plan. We need to start thinking about our incision designs from what I'm seeing radiographically. But let's look at a different CBCT image. What a challenging case. But like I had told you before, there's subtle nuances in this case that we need to pay attention to. Notice my bone heights, mesial and distal. Although I have a large defect, there might even be a little bit of bone right here, right at the crestal portion, which is maintaining all the tissue heights. Um, Interesting case. But let's look at this now from a lingual aspect. Again, very challenging case in terms of the amount of bone that's missing both horizontally and vertically. So what I want to do is I want to show you some photos from the surgery when we did the augmentation. So, yes, it's a one tooth defect. However, I know I need good blood supply, good vascularity, so there's going to be a large incision design to treat this one mandibular tooth defect. I also know too, I want to address the soft tissue component simultaneously with this ridge augmentation. So let's look at the photos from left to right. If you want to learn more about how the ridge augmentation was performed step by step, jump over into our surgical module. This case is highlighted there with the ridge augmentation surgery. I think you can learn a lot within that step-by-step tutorial, but for now, for the purpose of this treatment planning case, I just want you to understand that the ridge augmentation was done. So look at my incision design, right? I took the papillas on the distalmost portions. Why do I take the papillas instead of coming off the line angle? Because it's easier to close. Good full thickness flap, full thickness mucoperiosteal flap. I'm taking the periosteum with the tissue. Good dissection. Cleaned everything out and with this defect with rotary instrumentation. But I want to highlight on that photo on the left. Look at that large defect that's present. So, interestingly enough, I do have that island of bone, like we had talked about, and I actually have interproximal bone. I think that's my saving grace for this case in terms of the augmentation and why you'll see that it healed so well. So, two components to the augmentation itself. We're going to do a resorbable membrane tacked with Meisinger tacks. I'm going to use a mineralized cortical graft. I'm going to pin the membrane down at the apical portion. I'm going to pack my bone in. I'm going to take that membrane and I'm going to tuck it to the lingual aspect. After I get everything in place, then what I'm going to do is I'm going to do a subperiosteal mattress suture over the defect and even on the adjacent two teeth. So that's what you can see right here. These subperiosteal mattress sutures holding everything down and in place. So what I'm doing with this is I'm picking up the periosteum apical to where the resorbable membrane is placed. Now I'm able to add compression to maintain that bone stability during the healing process. Now, while I'm in, I also want to address that soft tissue component. So in the figure on the far right, you can see here I've used microderm layered over the resorbable membrane and sutured again with subperiosteal mattress sutures. So this is more of a sandwich type technique or a layered technique. This works really well in my hands. I want to address everything simultaneously. So when I come back to place the implant, my life is going to be a lot more straightforward. Here we are at 4 weeks. Again, the thing you're going to see in that step-by-step tutorial, yes, you'll see how I condense and how I pack the bone. You'll see how I tack the membrane into place. You'll get to see the most important part of the procedure, the periosteal release. You'll get to see how I get that primary passive closure to get results like this at 4 weeks. I used a combination of two different suture types. I used resorbable glycolon sutures on my two vertical components, and then I used PTFE across the horizontal aspect of my incision. When I'm doing a case that requires good closure long term, I really like to use the PTFE sutures. Although I have to remove them, I think they hold up better and they expand a little bit with the swelling as things are healing. Just another view after the sutures are removed at 4 weeks. I'm going to have that patient start resuming normal hygiene at this point, brushing, flossing, everything back to normal. That incision design will heal and it will fill in and epithelialize in those interproximal papilla over the next 5 months. So again, like we've talked about before with the digital workflow, what two components do I need? I need a STL file, right, and from an intraoral scan, and I'm going to need a CBCT image. Both of these are done at 6 months for this case. A good general rule of thumb when you're doing ridge augmentation cases is for every millimeter augmented horizontally or vertically, 1 month per healing. So in this case, a pretty large defect. Um, I'm going to take these scans at 6 months, but I'm going to wait about 9 months to go back in on re-entry for this case. I want that bone to be solid. In this case, the bone that we used was a mineralized cortical graft, that is going to resorb slower, which is what I want, and that bone is going to be harder when I go back in at re-entry for implant placement. So just looking at the intraoral scan in a couple different views. You had a facial view and you had an occlusal view. But now what we're going to do is we're going to start our treatment planning. This is a narrow space. This is a tight space. I only get one chance with this implant placement in one drill. So what we're going to do is we're going to design a 2 millimeter sleeve guide for this case. The proposed implant is a 3.0 Nobel Active Ti Ultra. And you can see here we have adequate space to safely place this implant. I normally don't do single unit implants in the mandibular anterior sextant. It depends on the root proximities, spacing, and making sure I can get that implant into an adequate spot. So the proposed implant here was a 3.0 by 15 with a surgical guide. So again, if you want more information about the DTX digital workflow and how I incorporate this, jump over into my modern periodontal concepts and you'll get to see a step-by-step tutorial about how I actually do this chairside with the patient. But for now, just know that with the intraoral scan and DTX Studio, I design a tooth. So now I'm doing a restoratively driven treatment plan. Again, here, just a different view. When I'm in the software, I like to look at things from all different angles to make sure I'm not missing anything, to make sure that the guide is going to seat passively onto the teeth. So I always print the guide, polish it, clean it. The total work time for this, it depends on the height of the guide. More often than not, it's about 20 to 25 minutes to print. Then there's an alcohol wash, and then there's a curing, and then there's a polishing, and then you need to place this 2 millimeter sleeve with a little bit of flowable composite through that secondary access hole. I tend to have my assistants do this for me, and they do it quite well. So we've gotten the digital workflow down precisely. So this works so well in my office using the Sprint Ray Pro 2 and their surgical resin. These sleeves, these 2 millimeter sleeves, can be bought through Noble Biocare, and they work wonderfully. I love these sleeves because they fit in. It's more like a lock and a key. The sleeve doesn't move around at all because of the design. It has those two wings right here at the two different ends of the sleeve itself. What I still like to do to this day is I will print a model and then I will try in the guide to make sure it fits passively so that I don't have to be adjusting this chair side at the time of surgery. Other benefits to DTX Studio are you can create surgical access windows if you wanted to for a larger guide. You can put initials, right? We can put Arcadia Perio right here if you have a lot of guides that you're doing. All of this software communicates with DTX Studio, communicates directly to SprintRay. If you want to see how that digital workflow works, jump into my Modern Periodontal Concepts module, and you'll get to see a general digital workflow overview. So here we are, ready for surgery with implant placement. So let's talk about incision design. So here we have good adequate tissue, good bone. Now remember, I'm going to remove that tack in the midline. I'm going to leave those two tacks apical near the canines. I don't want to make my flap that large just to gain access to remove those tacks. It is okay to leave those tacks in place long term. So we have kind of two different incision designs when it comes to this case. I know that there's a little bit of a still of a horizontal ridge defect at the most coronal aspect of the crestal bone. So I know I'm going to graft this case a little bit. So really what I'm thinking about is a mid-crestal incision to split the keratinized tissue, intrasulcular, and then a vertical release. I'm going to come over here to tooth number 25, intrasulcular, vertical release. Now I'm coming off the line angles at this case. Why? Because I know I have good thick tissue to suture to here from that microderm that we placed at the time of the ridge augmentation. Remember how thin that tissue was before? Notice how now I can't even see any of those root prominences, especially on the canines that we had talked about earlier. As you can see here in the keratinized tissue, still a little bit of hyperpigmentation. It was not a concern for the patient. Just know with my laser, the ND-egg laser, with the value-added procedures, we can do hyperpigmentation removal. More on that in this clinical case module to come. So full thickness flap design, and look at how amazing that bone looks from where we started. Remember the giant defect that was right in this area here? As highlighted by the red pen on the photograph. I mean, this is as perfect as it can be. Look at that tissue thickness that we have here and here from that incorporated microderm. This can be super easy to suture to. Now remember to keep in mind when we're placing the implants, I want about 4 millimeters to establish biologic width. So I'm always measuring this tissue height, and this is how we're going to determine where our implant body goes relative to the crestal bone. It's going to be supracrestal, equicrestal, or subcrestal. In this case, we're going to place that implant slightly subcrestal to establish that 4 millimeters of biologic width that we want to establish and maintain good alveolar bone around the implant itself. Now, one of the things that I do for all of my implants, like we've talked about before, and I will continue to talk about after, we're going to photo functionalize those implants, meaning we're going to treat them with a UVC light. What that light does is it removes all the hydrocarbons on that implant surface. It's going to change the polarity of that implant surface from hydrophobic to hydrophilic. Remember, that's going to increase the bone to implant contact, better long-term success and survival with photofunctionalized implants. The other thing that we're going to do is we're going to decontaminate that osteotomy with the ND-egg laser. Again, just a standard protocol when it comes to implant placement at Arcadia Perio. So here you can see the ND-egg laser doing the decontamination within the osteotomy. Now remember, this tooth was removed because of an apical infection. I want to make sure with that light energy it penetrates deep beyond the laser tip. So I'm going to make sure that ND-egg laser technology, that wavelength of light, is going to eradicate any of those pathogenic bacteria that may still be around. It's just a safety measure. It's my insurance policy to myself. I do not want to go back in and replace this implant. So I'm going to do everything I can at the time of placement to ensure the best possible treatment outcomes. So here we are, placing our Noble Active 3.0 by 15 Ti Ultra implant. You can see here, notice how on the implant body itself, along the apical threads, you can see the heme wicking up the implant surface. That's what I want to see. I want to see that hydrophilic surface. And remember too, what we had talked about before is this mark on the implant driver is 3 millimeters. So that gives me reference points when I'm placing that implant, I'm torquing that implant into place. Here we have everything closed up. A little bit more bone grafting was done at the time of placement with a membrane. And this is going to be my 5-0 glycolon sutures. Everything is closed up very nicely in this case. Knowing that I had to graft, is why I went one tooth on either side of the implant itself. So you can see here, implant placed slightly subcrestal, right, relative to my adjacent interproximal bone. But remember, I want it to be about 4 millimeters for biologic width. So this implant's placed about a millimeter subcrestal because the tissue was an average thickness of 3 millimeters. You can see here those tacks are left in place, and we're going to allow this implant to heal for 4 months prior to doing our torque test. Here we are at 4 months, maintaining wonderful tissue heights, good tissue quality. So this is just a facial view of that implant, maintaining the nice papilla heights, kind of pulling back and zooming out a little bit more to get a more full picture of this case. And now just giving you a occlusal view. Obviously with this patient, and as with most of our patients, we need to work on our oral hygiene. So even after I send this back to the restorative dentist, right, I want to see this patient back after the restoration is complete. That gives me long-term follow-up. So not only am I going to check the occlusion, I'm going to check the interproximal contacts, I'm going to take a radiograph, I'm going to take photos to see what the tissue looks like. Then what we're going to do is after that, I want to see the patient on an 18-month recall, even if it's for a single unit implant. And if those patients are coming in and if something goes wrong, I'm able to treat it quickly. I'd rather be proactive to these situations versus reactive and seeing these patients come back 6, 7, 8 years later now with implant complications. It happens. It happens to all of us. If someone tells you they don't have implant complications, they either aren't paying attention or they haven't placed enough, right? We see implant complications all day, every day. So I need to establish good rapport with the patients and explain to them the benefits of why they're coming in and why we're monitoring these long term. I rather treat this at the peri-implant mucositis stage versus peri-implantitis. A lot easier to treat gingival inflammation without the presence of bone loss. So again, just a fun case that was completed at my office from building up the bone in the anterior mandibular sextant to implant placement with a digital workflow component with intraoral scanning, CBCTs, and 3D printing to the surgical execution of the plan with predictable, precise results. So just want to re-go over and highlight those learning objectives. The three learning objectives I want you to take home from today's lecture. Being able to diagnose and treatment plan the mandibular anterior sextant, right? And understand when do we place one implant, when do we place two implants, what does that look like? When can we place one implant, maybe with two teeth? It all depends. It's all patient driven. What I find is it's varied amongst patients in this mandibular anterior sextant with root proximities in the adjacent teeth and how close things are. Sometimes I don't have enough space to safely place an implant in that mandibular anterior zone. And then we need to determine the indications for the ridge augmentation and delayed placement. Understand how we utilize 3D technologies in DTX Studio to virtually plan a restoratively driven treatment plan, getting that implant into the most ideal position possible, and being able to translate this into a precise and prosthetically driven workflow. Then I want you to be able to design and fabricate an in-office surgical guide. I want you to understand how all of the technologies and how all of the systems communicate with each other. You have the DEXIS ecosystem with DTX Studio, communicating directly to SprintRay technologies. Everything works seamlessly. So if you're new to 3D printing and you want to learn more, again, jump over into our Modern Periodontal Concepts module and you'll understand that workflow in a little bit more detail. So again, thank you for jumping in on today's case. Just a fun case to do. So I look forward to seeing you back here next time to do clinical case 7. This case that we're going to talk about in clinical case 7, it will be a LANAP case, a periodontal disease case that was treated, a unique case that'll highlight trauma from occlusion and how alleviation of trauma from occlusion and treating the periodontal disease will allow for bone regeneration. So just a sneak peek of what's coming next. And what I want you to do, take that 3-question quiz after this lecture and get that CE credit emailed over to you. Thanks again and have a wonderful day.